Hey, good morning, everyone, and welcome to Euronurse. You can see I'm not remote anymore. I'm over in my home studio. Happy. We meet every Saturday at 9 a.m. Central Time. Glad to be with everyone. If you're watching us on YouTube, LinkedIn, Facebook, X, or Instagram, welcome to the show. Yes, we're in all of those places now. Also, if you're on YouTube, be sure to hit that subscribe button. Keep our subscription base rolling along. They're doing a great job. It's crazy. We're doing, I think, about 1,100 subscribers now. This is your first time visiting us. Be sure to check out our program, our website at euronurse.com to learn more about the show. Best place to go to find out all there is to find out about the show. It's also the best place to go to watch all of our past episodes. We have 74 of those now to watch, so check them all out. Hey, you want to listen to us in your car? No problem. Go to Euronurse Plus and find our audio podcast. Any of the audio podcasts that you want to listen to us. I just got back from driving back from Florida, and I was listening to some of our own podcasts, and it sounds pretty neat. So it's a neat way to listen to the show. If you're not getting the newsletter, be sure to go ahead and fill that out on our website. You'll get a newsletter every Monday and a reminder on Fridays about the show starting. And if you're watching us live, comment box. Go ahead and put your comments in there. We'll bring them up on the screen for our experts to answer. This week, we're really lucky to have 3 reps from the ABC Medical Group. They're going to be talking about how to increase efficiency and satisfaction in your practice with how they can help us out with that. And let's go ahead and bring in our experts right now. Experts, let's bring you all in here. There we are. Look at that. Got a big screen full of everybody. Welcome to the show. So this is the point where we do our introductions, and I'm going to go ahead and kick it off myself. I'm Vic Satis. I'm the host and producer of the show. Been involved in urology for 40 years. My big love of putting this show on for you guys and paying it forward is always great. So really enjoy putting on the show. Interesting story for today, just for those of you that haven't heard about it, but we're going to be launching a new podcast called the UroPatient Podcast, and that's going to follow this show at 10:30 Central Time. So be sure if you want to learn more about, as a patient, you want to learn more about the show, check that one out too. All right, let's bring in Andrea. Go ahead and do your introductions.
Good morning. My name's Andrea Strong. I'm a urology nurse practitioner in Wisconsin. I've been working in urology for over a decade now. Many of that time I spent working as a nurse. I did inpatient, I did outpatient. I did get certified as a urology registered nurse. I'm also the educational director for the Chicago Metro chapter of the Society of Urologic Nurses and Associates. And I am on the board for the National SUNA as well. So really happy to be here with you all today.
It's a shame you're not involved more. Hey, John, go ahead.
Good morning, everyone. My name is John Lin. I'm a urologist in private practice in Gilbert, Arizona, which is just a little bit south of Phoenix. And like Vic, what I'm doing here is to pay it forward, sharing what little I know in the clinical and business aspects of medicine so that we can help all urology practices to succeed. As such, I created a Facebook group called the Thriving Urology Practice Facebook group, where we have over 2,500 US-based urology practice folks joining and interacting on a daily basis. The story I have for you today is that interesting thing that's about to happen as soon as I'm done here is that I have a locksmith coming to crack open a safe that no longer opens in our practice. It contains, get this, prescription pads. Yes, I locked those prescription pads in there and along with some other paperwork. So that is the interesting story of the day. I tried everything I could to crack the safe. Everything known, looked online, everything, could not do it. Even took a circular saw to it.
Wow.
I need expert help. So just like I need expert help in cracking the safe, I encourage all the patients or urologic patients listening to this to not to take your urologic care in your own hands. I have treated quite a few guys who insert needles into their scrotum to drain their hydrogel. So don't do that. Back to you, Vic.
Yeah. All right, Scott, we're going to bring you up here. Go ahead and give your introduction.
Hey everyone, Scott Woods. I'm the marketing manager at ABC Medical. We're a nationwide medical supply company. We specialize in wound care and ostomy products, but our real forte is urological products. That's kind of where our heart is. I'm the least interesting person on this call, so I'll end it with that and turn it over to one of my cohorts at ABC.
All righty, real good. All right, Zach, you're up.
Hello, everyone. My name is Zachary Tierney. I've been with ABC for about 3 years and some change now. Interesting fact about me, obviously, I don't have the credentials that most of the individuals do on the show today, but I know a lot about catheters. I've been a patient myself who has had to use catheters as a child. So I understand the emotional roller coaster that patients go through when it comes to just being told you need to cath. So from an emotional and mental standpoint, I'm able to connect with patients during my day-to-day responsibilities with my job. But when it comes to meeting with clinicians, I've got a real strong understanding of insurance and criteria and kind of what goes into getting patients approved for supplies, ultimately saving the clinic time in the form of addendums and having to go back and fix documentation to meet criteria for the insurance company. So yeah, that's what I specialize in.
All righty. And Amy, go ahead and introduce yourself.
Hi, my name is Amy Landrum. I am a wound ostomy continence nurse practitioner. I work as a clinical advisor for ABC Medical, where I can provide kind of a clinical perspective and clinical support, both to the people who work at ABC Medical, as well as our customer basis and the clinicians who use our services. I think in terms of what I can offer here today is I'm a product expert. So I know a lot about products. I know about what products, excuse me, can work well for certain situations. I really delight in finding patients the ideal products. I enjoy it. And so in addition to ABC Medical, I still work in clinical practice in my community, working with real life patients. And I do some low cost and free medical care as well.
All right, great. All right, I'm going to bring up your slides, and if I've done everything right, you'll be ready to go. I did. It's all yours.
All right. So I'm going to talk about best practices with teaching self-catheterization. And next slide, please. And so I'm not going to, there's a lot of things that I think probably could be included in this slideshow. The things that I'm going to focus on are things that are around kind of helping patients find the best products. And by that, I mean a catheter that works well for them and a catheter that they can use. So I think number one, before I start working with patients to figure out what's going to work for them, is I take a look at my patient beyond just their clinical picture. I want to take a look at the social determinants of health. And by that, I mean, what resources do they have? What education level do they have? What knowledge do they have about intermittent catheterization? What kind of support systems do they have? And I want to look at both their strengths and their limitations and really tailor my education and my, what I'm going to offer them around that. Next slide. Some of the key education points that anybody teaching intermittent catheterization needs to touch on are going to be equipment review. How do you use this thing? Hygiene. How are we going to use it and reduce the risk of complication? Insertion technique. How do you put it in? And how do you put it in a way that's going to be comfortable and not scary? Because a lot of times, as we know, when people are first doing this, it can be a lot. It's a lot emotionally. It's a lot to wrap your head around. Obviously, how can we drain it in a way that's going to be accessible? And this really makes me think about folks that are in wheelchairs or that might have, hand dexterity problems, things like that. We need to think about how we're going to do this in a way that's not going to be a mess. And then appropriate disposal, which is pretty straightforward. Patient and positioning and insertion technique. This is kind of, again, where we need to look at this individual patient. What are their functional abilities? What are their environmental considerations? And what are their preferences? Next slide, please. So follow-up. This is one of my favorite things to emphasize. Follow-up is really important. So when somebody is new to using catheters, 2 to 4 weeks is a great time to follow up. This is going to give you an idea of how things are going. That initial follow-up, you can learn a lot. How is it going? Is this product working well for them? Are they doing it right? It's going to make them feel supported too. And then, after that initial follow-up, the follow-up frequency is going to be something sort of a shared decision between you and the patient. How much support does this person need? If they're doing great, less frequent follow-up. If they're still kind of shaky at it, maybe more frequent follow-up. Follow-up can be as simple as a phone call. Next slide, please. Another key element that I think is essential to any folks that are new to intermittent catheterization is making them aware of the complications, just so they can act quickly or act appropriately if they encounter these situations. So, there's more complications than just this, but the ones that are good to emphasize, urinary tract infections, not just that they happen, but what are the signs of them, bleeding, because this, sometimes this may not be an emergency, but it's alarming to the patient. So we like to talk about what to do about bleeding, what it could be, next steps. Difficulty in passing the catheter. If they're having trouble getting it in, what do they do? Who should they call? Next steps. Leakage between catheterizations. This is one that I think sometimes gets left in the dust a little bit, because it's not such an emergency, it's not such an alarming thing, but it's very distressing to the patient. So if catheterization is not reducing urinary incontinence, what are our next steps? Who do they need to call? What can we do about that? Pain and discomfort, and then just specific complications that the individual might experience. For example, autonomic dysreflexia with your spinal cord injury patients, and just make sure you're including who do you call, when do you call, what's an emergency, what's not an emergency. Next slide. So that's kind of I just touched on some key points that I think everybody should be including in their new patient education plan when they're teaching folks how to cath. There's other things too, the fluid intake, follow-up, things like that, that I think we definitely usually include with our stuff. But I think, follow-up is really important. We're going to talk more about that. Let's talk about how to find the right catheter for the patient's unique situation. So we can go to the next slide. I always ask this question, and I get interesting answers sometimes, but so what's the best catheter on the market? And you guys don't have to answer, I'll answer myself, but the best catheter on the market is the one that the patient wants to use, right? And so that's kind of where the art of finding the ideal product comes into play. That's what you really want to focus on. Is we all have our biases. Oh, I love this company, the rep's really cute, or I love this company, I just love the way these catheters look, this is what I would use. I think it's really important sometimes to kind of put that bias out the window when you're actually working with a patient, because the most important thing is finding the ideal product that makes them feel like they want to use it, because then they're going to be compliant, they're going to feel better about it, it's going to be less distressing. So the basics, I think we're probably familiar with it, but we want to use a sterile single-use catheter. We want to teach clean technique. This is what we do for intermittent catheterization. Due to hypersensitivity and the risk of latex, we typically steer clear of latex products. And the good news is most products don't contain latex anymore. So most of your companies are going to offer a wide array of non-latex intermittent catheters. Next slide. So here's the slide that has all the, this is what I think about. And I think everybody should think about. Again, it's kind of about individualizing the experience for the customer or the patient. Consider their anatomy and consider their environment. These are really unique things to this individual. So picking out the ideal catheter is less about finding a brand that you like and more about looking at this person's body. Like, what's going on? Do they have an enlarged prostate? Are there other anatomical features that might make catheter insertion more difficult? And if so, what catheters can help us kind of navigate around that? Do they have hand dexterity issues? This is one that gets missed a lot. So we are always looking at the catheter. Why don't we take a look at the packaging? How easy is it to open? If they have arthritis, or if they're a higher level spinal cord injury, quadriplegic, These things are important to consider. What kind of hand dexterity do they have? And is it going to be compatible with opening this product? Lower extremity contractures, another great thing to think about. How's their visual acuity? Are they ambulatory, or do they spend the majority of their time in a wheelchair or bed? And this is important to think about too, because this is going to make you kind of think about, well, what catheter length really makes sense here? Where are they cathing and into what? Do they have a large pannus or other anatomical trait that might impact how they cath? Are they going to be able to visualize their urethra or no? Would a female length catheter be helpful, or would it maybe not be helpful? Just depending on, again, how can they reach their urethra and how can they reach what they're going to be cathering into if they're not using a closed system? And then, is there a caregiver available to assist and reinforce teaching? Or is there not a caregiver available? So these are the things that I tend to think about when I'm first working with a patient. Next slide. Samples on hand. Keep samples on hand. This is something that worked really well for me in clinical practice, and so I'm going to share it with you guys. Catheter companies are more than eager to give you samples, right? Because they want you to use their products. So develop relationships with your catheter manufacturer. We got cold. I'm going to give you a whole list and all their contact information at the end of this presentation. Keep that on hand. But consider getting sample packs in several different French sizes, several different styles, male and female length of 3 or 4 or more brands of catheters, and keep them on hand. This is a really great way for you to get familiar with these products as well. Because it's one thing to look at a product in a package or listen to a rep tell you about it. It's an entirely different thing to take it out of the package and help somebody put it in their urethra for the first time, because you're going to really get some hands-on experience with it. And you can see how it performs, and you can kind of see what it's like. And that way you're going to be more of an expert on that product when your patients come back to you with questions about it. So keeping samples on hand in the office so you can go over them with the patient and learn about them together is a fantastic choice. Next slide, please. Follow-up and feedback. This is how I learned everything I know, really, about products. So when we hand out products to patients and they take them home, when you follow up with them, you're making the patient feel supported. They know that you care. They know that you are providing them with an access to a resource, which is you, to help them with this. But you're also collecting information on how that product performed. So if they give you feedback like, well, it went okay, but it was just a little too soft. It was really hard. This one thing I didn't like about it, or it was okay, but I just have such a hard time opening the package. Or it was okay, but water just spills everywhere, and this doesn't work for me because I'm at work when I'm cathing and it gets on my clothes. Whatever information they're giving you back, you file that away in your little library in your brain, and then okay, so this catheter right here, the things that they're saying that work well for it are the following, but the things that they're saying that they don't like about it are the following. And I'm going to remember that. So next time I know when I work with a patient, if this one attribute is really important to them, then I won't give them this catheter, or I'll make a different recommendation. So that follow-up and that real patient experience, that real world experience is what's going to make you truly understand products and how they perform and how they differ from each other. All right, next slide. Explore assistive devices. These aren't always as readily available, but they can be, and in terms of just people being familiar with these products, both clinicians and patients. But there are a lot of different assistive devices out there that can help people with the catheterization process. And again, this kind of goes back at looking at your individual patient and where their strengths and weaknesses might be in terms of their ability to cath themselves. And if you identify specific deficits, then look into assistive devices that can kind of help with that deficit. There's a lot of stuff available. Next slide. I think DME companies can be a fantastic resource. I'm with the ABC Medical, but I can't speak for all DME companies, but I know that we are excited to help sample folks. And so we can sample your patients different things for them to try. And not only that, we can provide them with product support. That's what I do for the company. I do other things too, but a big part of what I do is work with patients that aren't doing so well on their current product and want to experiment and learn about other things that might help them be better at catheterization and feel better about catheterization. So that is something that we can definitely help with. We can partner with you, and we ultimately respect your choice as the clinician and the patient's choice as the patient. So we're not pushing anything on anybody, but we can certainly show them what's out there in terms of the world of products and devices that can make it easier. I'm a continence certified nurse practitioner, but I'm also wound and ostomy certified as well. And so, and I do this in the real world as well. And I'm always happy to support any questions, any concerns. I have clinicians email me all the time, hey, we're trying to figure out what ostomy product would best work for this guy. Or, this catheter, it worked great, but it's not covered by his insurance. What else is out there that's similar? These are things I can help with. I included my email here. Feel free to reach out anytime. The last thing I want to say is the following slides are really a handout for you guys. If you'll scroll, or if you go to the next slide, I'll kind of show you. So I have, you can go kind of quickly through all of them, but I have the major catheter manufacturers here for you. This is a reference. And I have their emails, their websites where you can look at their products, and their phone numbers that are for the clinicians to call in. And this is how you can get samples and product support from any of these companies. So if you wanted to kind of put a little library together of a bunch of different catheter products to keep on hand in your offices for your clinical practice, so you can get familiar and teach patients, this is how you start. So contact these manufacturers, get them to send you sample packs. This is it. That's all I have to say. I'll save the questions for the end, and I'll let Zach go ahead and take over. Thank you so much.
Thank you, Amy. Those were great points, and I think it's a great segue into my portion of the presentation. So really what I'd like to do during my 15 minutes of fame here is to bolster one's understanding of Medicare requirements, and then also optimize your referral submission process. My goal is to make every portion of the presentation make sense, and so that you can apply it to your day-to-day findings or interactions with patients. Next slide, please. So we're going to get into Medicare requirements, and I'm going to speak kind of in general term, but also in layman term. I don't know if everyone on this call or watching is tenured in their position or not. So this is a great way to get started if you're new, and if you're tenured, this is a great refresher. So A4351, a straight tip catheter. There's some requirements that are necessary for documentation purposes in order for a supplier to submit and to be able to bill for those supplies, and then essentially over time for the patient to gain renewals when needed. So there's some key points here that I want to speak about. One is frequency. The second is permanency, and the third is diagnosis codes. So look at frequency here. How many times is the patient cathing a day? Let's just say 3 or 4 times a day. Permanency. The word chronic is really important here because it shows that the patient has had an issue for more than 3 months. If it doesn't state in the notes 3 or more months, the word chronic is really key here. That'll kind of bypass the additional wording. The diagnosis codes. We're going to need to see retention or incontinence in the notes in order to meet Medicare or Medicaid's requirements for diagnoses. This has to be addressed in the notes. If it's not addressed, we're unable to get the patient the supplies. Ultimately, that just leads to the patient calling the clinic. You end up having to make a phone call to us, the supplier, and we're going around in circles. And ultimately, it just delays the patient being able to receive their supplies in a timely manner. And ultimately, we get into our positions either on the supplier side, manufacturer side, or in the clinic to help these individuals obtain what they need to live a more dignified life and a healthier life. So here's a great example. Mr. Smith must self-cath 3 times per day to manage chronic urinary retention for 3 months. This will get a patient a straight tip catheter in a heartbeat, and it'll make our job very easy on the supplier side to process the order. Next slide, please. This is where it gets a little bit more complicated. And from my perspective, this is where I see a lot of documentation goes awry or kind of strays. A4352, a Coude catheter. It requires the same documentation as a straight tip catheter. However, there's a key phrase that needs to be used, and we're just going to use an example here. This is not in any way us telling you this needs to be in the notes, just an example. Patient is unable to pass a straight, requires coup to pass. The insurance company wants to know that the patient has trialed a straight tip catheter and has had issues passing the straight, and they want to know for sure that the patient needs a coup catheter. All catheters are coded to insurance and are billed the same. However, a straight tip catheter is billed differently than a coup catheter, even though it just has that tiny curved tip. It costs slightly more to the insurance company, and so on and so forth with a closed system catheter. So they want to make sure if they're going to be paying more, the insurance company that is, that there's documentation there to support that. Patient is unable to pass a straight, requires coup to pass. It could say due to patient's anatomy, patient is unable to pass a straight. I've even had examples where patients, their dexterity is very low, and we've been able to work with clinics to have that documentation along with a similar phrase here, kind of combined in a way that allows a patient to perhaps receive a catheter that isn't your standard 14-inch straight catheter, even if it's a coup. There are catheter designs now that are not your stereotypical standard catheter. Some come in a ring, some come in pocket-sized packaging. So this type of documentation helps a patient obtain that coup catheter when needed. Next slide, please. So this is really where I'd like to spend most of my time speaking. Closed system catheters. Now, obviously, to Amy's point, we want to provide these supplies to patients where necessary, but this is a very cleanly process when it comes to a closed system catheter. It's sterile. So there's specific documentation that we have got to have. And there's been some changes recently to Medicare and Medicaid that I'll speak to after this slide. I won't call it a loophole. It's just it's giving us more room to breathe when it comes to specific documentation that the insurance company will accept. So 2 UTIs within a 12-month period while using sterile catheters. This is a really important point. I'll typically get submissions for patients needing supplies, specifically closed system catheters, and a patient will have been using a Foley when they've contracted a UTI. The insurance company will not allow or accept this documentation. It has to be on a sterile straight tip catheter, or a coup catheter for that matter. But it needs to be on a catheter that is not a closed system and is not a Foley. That's really important. I want to just make that clear. The UTIs need to be separated by 30 days. It can't be 28 days. It can't be 27 days. It needs to be more than 30 days. I don't necessarily agree with this. If a patient's getting a UTI, it's a clear sign that something's not working, and we need to work towards putting the patient on a product that will work for them to reduce the UTIs. But this is the current ballpark that we play, and this is the documentation that's going to get those patients approved. So there's some key secondary symptoms here that you also have to have documented. So you could have 2 UTIs separated by 30 days within a year, but if you don't have these key secondary symptoms, the insurance companies just won't accept the documentation, which I know sounds crazy, and we're all probably rolling our eyes at this point saying, oh, come on, but this is really important. And I'll just speak on a few because there's quite a bit. Secondary symptom could be increased urgency to urinate. It could be increased incontinence. It could be a fever. It could be, again, any of those three are really kind of where I see easiest documentation being obtained. If you go down this list here, it could be appearance of new increase in autonomic dysreflexia, spinal cord injury patients. It could be pyuria, etc. Next slide, please. And this is in addition to the information we were just talking about. There's some other options here. Immunosuppressed patients, documentations as far as like their medication list is going to be really important here. If they're on a specific drug that is going to obviously like chemotherapy, or any of the other drugs that would be on this list in front of you here, prednisone, methotrexate. If we have those documented, we can get the patient approved. It just needs to be in the medication list, and there needs to be some note of retention aside from the UTIs. That's really, really important. Option 4 and 5 kind of go like what I just talked about: a spinal cord injury patient, perhaps a female who has a neurogenic bladder, who is pregnant for the duration of her pregnancy, can qualify for sterile catheters. That's really, really important to note, that as soon as the patient is no longer pregnant, they would have to come off of the closed system catheter. Option 5 I'm going to speak about here momentarily, but patients that have obtained an injury that is T3 or higher, I don't want to use the words auto-qualify, but they qualify. And I'll get more into that here with the next slide. Next slide, please. So required information, and this is going to go with my last slide, actually, which is a snapshot of our RX that we use at ABC Medical. And with respect to everyone that's listening today or who will be watching this in the future, whichever script you decide to use that you trust as far as the supplier or the manufacturer, these are going to be many of the required pieces of information that we are going to need on our end and the insurance company is going to need on their end. An order date, patient name, diagnosis code, product being ordered, length of need. That's one that I see missing quite often: length of need and number of refills. That's typically section 3 on all scripts that across all suppliers and manufacturers. We typically follow the same structure when it comes to our ordering process and how we lay things out for the insurance company. And really, we use their criteria. So length of need and number of refills, that's a big one that I see missing quite often. And it ultimately leads to us having to then fax or email or hand deliver a certificate of medical necessity, a CMN, to the clinic with this missing information based off of our conversation with the patient. And then it's up to the doctor or the clinician to be available to sign and date that new piece of documentation that we would then submit to the insurance company. So you can see we go around in circles pretty quick if a basic piece of information is missing. We definitely need ordering physician name and MPI. That's huge. I know that sounds kind of crazy because the doctor's signing. Why does the patient or the doctor's name, nurse practitioner name, PA's name, why does the provider's name need to be on the order? Well, sometimes we're working really quick. Doctors move from room to room and typically don't have a lot of time to spend working on the beauty of their signature. So it's a quick signature and go. Typically. And if we can't read the signature, the name of the provider has got to be on there. And that is really key. And I'm harping on that, but it's really key. It's something that I see that goes missing. And again, it kind of leads into that carousel effect where we go around in circles and we're not actually getting to the end result, which is getting the patient supplies in a timely manner. And then again, signature, but also the date. Want to make sure that the date's on there. Again, that's just a verification process for the insurance company. If it's not on there, it'll throw a flag and we'll go back into that carousel effect. Next slide, please. Okay, so T3 or above. So if a patient has a T3 spinal cord injury, again, they don't automatically qualify, but they qualify. And I get excited here because this is different than a patient having to have 2 UTIs within a year, separated by 30 days with secondary symptoms, so on and so forth. It just gets very difficult, especially with where we are at in healthcare today with standards, with number of patients that are needing our assistance. And then from my end, with the number of clinics that entrust me with their patients, the UTI conversation it just gets old, and it takes up y'all's time and it takes up my time. I said y'all, that's my Midwest, my Midwesterner in me. So anyways, T3. If a patient has a T3 spinal cord injury and it's documented in the note, T3 or above, and I'll give you an example. Patient has sustained a C6 injury due to automobile accident, patient will require, patient has retention, a permanent urinary retention, and will require the need of catheters in order to void bladder for the rest of patient's life. If patient does not receive these supplies in a timely manner, patient could have complications, could cause harm to self, could ultimately end up hospitalized, or ultimately, death is a factor here. If we're not voiding our bladders, and death is a strong word, death is a factor. And, that's something we're obviously trying to avoid, especially with patients that have gone through trauma, significant trauma in the form of a spinal cord injury, let alone just urologic, day-to-day issues or incontinence issues. Those words that I just said, they make the insurance company pause. And with that permanency language, as well as the location of the patient's injury, we're able to get patients closed system catheters without having to jump through the UTI hoop. And to me, that's a huge win. And hopefully moving forward, we're going to end up in a scenario where all patients with spinal cord injuries, regardless of location of the injury, will qualify for a closed system catheter. That's my hope and wish. And I think there's a lot of individuals out there now with injuries and without who are lobbying for that. So that's really where I'm hoping healthcare goes here moving forward. I don't know what the timeline will be. And again, this is just a photo. Obviously, if you're in a rehab space or you're seeing spinal cord injury patients, this is the spine, obviously, and we're highlighting the T3 or above sections that would essentially qualify a patient for closed system catheters. Next slide, please. This is a quick, brief snapshot of ABC's RX that we use. Obviously, it's small. I don't know if on your monitor you can see this well, but I'm just going to highlight a few points. You'll see a number 3 there and number 4. That's a really key area. Number 4 especially. Number 4 is the order date. I see that missing constantly. That is really where the prescription will start. That's the start date for when we can start supplying the catheter. Let's see here. Number 7, the signature and date section that I talked about. Those are key. You've got to have the date at the very end. I know it sounds crazy. If we have an order date and we're missing the signature date, why does it matter? It does. It's really, really important, guys and gals. And the last thing I'll speak about again is the length of need and number of refills. If you check one box and the other is missing, it's going to throw a red flag. We have got to have both of those marked in order to meet the insurance's criteria. And if you ever have questions, concerns, please feel free to put your questions in the comment section here. And if you need my email address, I'll happily provide it. It's been a pleasure speaking here today with Amy. And Vic, thank you for this space. This is amazing. And we here at ABC Medical are always available to help any of your patients that would need any urologic supplies, or if you just simply need some of this information that we've supplied here today, we'll happily provide it via email. Thank you.
Hey, thanks. That was really great. Appreciated all the good information that you shared. Just rearrange my screen a little bit. The any questions that came in from our audience, Andrea?
I believe we had a question from Katie, and it looks like she was asking how to order assisted device. I'm not entirely clear on that. Katie, if you could give us some clarification on that. And in the meantime, I just really wanted to thank Amy and Zachary for all this information. Amy, thank you for covering the social determinants of health, because that is so important. It's often overlooked, and it's really core to nursing practice. So thank you for that. And I just want to share a little bit of tidbit information, some just interesting things that I've learned over the years with catheters. If you live or work in an area that has extremes in temperatures, for example, me in Wisconsin, we get really cold, and Dr. Lynn in Arizona gets really hot over there. Remind your patients that when they're getting these shipments of the catheters, they shouldn't be leaving it in the garage or in their car where it is subject to those temperature swings. I've had some patients who were doing ice fishing, and catheters can get a little bit too cold with ice fishing.
Well said.
That's great. My comment that I had is, one of the things that I always look at is when teaching a patient how to do intermittent catheterization, I think it's really primarily my, duty to try to figure out what's the best catheter for the patient. I know there's been some companies that have come by and they just put these kits together and just give the patient all these catheters and let them figure out which one is best. And to me, that's a disservice because they don't know what one catheter from the next is. I like the fact working with somebody like ABC Medical, that's not one particular company. You're not necessarily locked into one particular brand. So I think that's really speaks to the necessity of seeing a professional, as John had talked about earlier. You don't trust your health to just anybody. Make sure that somebody's teaching you how to do this so that you learn the proper technique and help guide you into what catheter. As you spoke earlier about, there's just so many different choices out there. It's important to have somebody that guides you. And I just wanted to ask Amy, so what is your role in as far as like helping patients with problems and issues with catheters? I know sometimes they're calling the companies, not us.
Yeah. So at ABC Medical, typically what happens is we have some really great customer service representatives, and they're not nurses, but they're knowledgeable. And they understand when something's beyond their scope to help with. And so if a customer is calling in and like you said, it is almost, it's surprising to learn how many patients are in fact letting their DME company know that things aren't working out for them. How they get to me as a customer service representative will make note, okay, this guy is not, things are not going well here. He's struggling to put the catheter in. He's having a complication. He's, he has questions that I'm not comfortable answering. Or his insurance is no longer covering the product. This is a big one. His insurance won't cover the product that he was comfortable using. What next? And so they refer him to me. I'll get an email. I'll call the patient back within 24 hours. A lot of times I do a lot of encouraging of the patient to, hey, have you talked to your urology team about this? Because they're your number one support. They can help you with this stuff. But in terms of product support, what I will do is I'll talk to them about all those questions that you saw in my PowerPoint. Like, how about your hand dexterity? How about your visual acuity? How about, what's not working for you? What would you like in a catheter? I'll spend a long time and I have all the time, I have more time. This is what they hired me to do. So I have time to have these long conversations with customers over the phone and patients over the phone, and really get a picture of what's not working and what might work better. And then I will send them samples of what I think will work. Same French size. I'm not changing anything up like that, but a different style of catheter. And I'll also encourage them, hey, and if you need hands-on assistance and you want more support, call your urology team and bring these samples into the office and let them show you in person if this phone call isn't enough.
Yeah, I think that's huge. Hey, John, do you have any questions about billing? I know you're always.
I have tons of questions, actually. First of all, Zach, can you clarify what is a closed system? Because when I'm looking at these codes, A435152 and 53, 53 is a closed system, but in the descriptor, it says intermittent self-cath kit. So can you clarify what is a closed system?
Closed system catheter is essentially a no-touch catheter. So when we talk about sterile versus non-sterile catheters would be your stereotypical straight tip or stereotypical coude catheter without a protective sleeve.
Got it. That's it.
The protective sleeve is really key. But in addition though, John, there's the bag that's associated with the closed system catheter. Obviously, the urine has to go somewhere. So that's really where we find the difference when it comes to the coding of catheters and the billing of catheters. Something to keep in mind is that there are coude catheters out in the market today. I won't specifically name names. I don't think that's the platform for this, but there's catheters out there that do have protective sleeves, that have introducer tips, that have specific items that are designed to reduce UTIs and to be more sterile without being coded as a closed system catheter. So I think that's really cool to note. And if you want more information, or if anybody would want more information on those specific catheters, they can reach out to us at ABC.
I think Hollister sells them, right?
Correct. Yeah. Hollister is a brand that has those. Coloplast is one as well. I work very closely with Coloplast and Hollister. Their products are great. They have a lot of innovation that they put into the design of their specific catheters versus just, let's make a catheter that's cheaper, that we own, that we can bill at the same cost for this, versus a Hollister catheter that costs more and is billed, at 25 cents, just like our 5-cent catheter. I think it's all about what's really best for the patient versus the supplier or the manufacturer at that point. I think that's how you start to weed out who's really there for the clinic and who's there for the patient at the end of the day, not just for initial sale, John, but for lifetime if needed.
Yeah, great comments, by the way, on the documentation requirements. I teach coding and billing, and documentation is the bane of our existence as healthcare professionals. And I'm just literally looking at my order sheet, my order in my electronic health records, and I'm proud to say that I do have the size, the duration, frequency, quantity, and indications. And I pre-populate the indications, and it's easier to remove what is already there than it is to write things down and put it in the record. So I have urethral stricture for self-dilation, neurogenic bladder, urinary incontinence. That covers most of the reasons that I'm ordering A4351523. That covers all that, so I can just remove what is not pertinent to this particular patient. So that I don't forget, because I hate getting those letters of medical necessity and having my staff fill it out. A total waste of time. And I, having sat through a lot of pitches as an angel investor, and this question is for Scott. We talk about, you and I can talk about CTA, CTV, CTA, CPM, LTV. But my question for you, Scott, is what is ABC Medical's unique selling proposition? What makes you different than other DME vendors?
Good question. Zach spoke to it, even Amy throughout their talks, but we really want to put customers on the product that you choose for them and that they choose. So we're not looking to move them off of that. And there are some situations where insurance plays a role in what they can be put on. And so, but we're wanting to put them on the best product that their insurance will cover. But ideally, like there's not switching of products. I know that we hear of that taking place in the market. And as I've gone around and spoken to clinicians, sometimes they're not aware of it. When I ask, how do you feel about that? I've never had someone say, I don't care. That's one of our unique value propositions that we offer. And I think also just truly putting patients first. When I first came to ABC, I was a little weirded out that every single day we come together as a team across the nation, unless you're in an in-service or something, and we have a little, what we call a huddle, and it kicks off by this promise that we have. And the promise, I won't say it here, but we've all memorized it, and it's all about we will do whatever is best for the patient. We will work harder than any other company to make sure that that's always in consideration. So I was taken by that when I first started. And then when I got into a bunch of meetings and meeting after meeting after meeting, month after month, when big decisions were made about that were going to impact the company, the question would always be asked, but how is that going to affect the patient? And so I think those are two really big components of the heart of ABC, but it also helps clinicians, because if we're constantly, even having people on staff like Amy, we're trying to care for the patient, they're less likely to call you. So that's something that I often talk to clinicians about, like, why do you use ABC? And their comments are, because when I send something, it gets taken care of. If there are problems, because we're not in a perfect world, but if they are, you've got reps like Zach who are tracking orders from the time they were released until it goes to the patient and just following it step by step. And if a problem pops up, they jump on it. That just results in less calls to clinicians. So regardless if you work with ABC or not, that's something that I think you should hold your DME companies to a high standard to put patients first, to as Amy stated, to partner with you to achieve your goals. And if that DME is really caring for the patients, I think everybody says that, but if you're seeing that worked out practically with how the patients are being cared for, it's going to free you up with have more time on your hands, because you're not going to get as many phone calls from the patient because they're frustrated. They got inaccurate orders. They didn't come on time. All the things that you guys hear about more frequently than you should.
Sounds like what you're saying is that you try to decrease the friction from our end as a healthcare professional, and your company is extremely patient-centric, and so much so that you are reiterating that at every single meeting.
That's correct. Thank you for your summary.
Love it. We do have some questions coming in. Katie had a question about how do you order those assistive devices? For example, the leg spreader with a mirror attached.
I can take that. So unfortunately, a lot of these assistive devices are not necessarily covered by Medicare and insurance. And so that's a realistic, that can be a hurdle, it really can be. And so these devices, again, they're not always covered by insurance. Commercial insurance, you may have some more leeway with, but a lot of times they are not. And so it would be, my recommendation is to look, there's a lot of places online. Rehab Mart is one that I use a lot, but there's one called Rehab Mart. And there's some other places too, where I just look, honestly, here's what I do. I look for the device that I want to get. I Google it and I pick the one that is most affordable to the patient, if cost is an issue. And then I give them that information. Unfortunately, like I said, insurance doesn't always cover the things that we actually need it to cover many times. I think we all know that. But again, we can find these devices, and it's usually not, what's reasonable to one person is not always the case for another, but usually you can find under $100, you can find this stuff.
Okay, great.
I believe you can get some of the lighted mirrors for free from companies like Bard or Coloplast or Hollister.
Yeah. Yep. The lighted mirrors for sure. And that's a great tidbit. Thank you.
We have another question that came in from Susie Swain here. What's the best practice to get a more frequent catheterization for a patient? So there may be a unique situation. Let's say the patient is creating a lot of urine because they're on certain medications that do that. They also have a non-compliant bladder, and they can only hold a certain amount of urine before it's dangerous to their kidneys. How do we get more frequent catheters, more than 6 a day?
Ooh, I can take that one. That's a really good question, Susie. So really, it's going to come down to the insurance company. Letters of medical necessity. So an LMN, as anyone in the healthcare industry knows, can be very, very helpful in these cases. State allowables, I've worked through a few of these situations, and I won't obviously name any names at this point, but there's been some children that I've worked with recently who have needed both Foley catheters as well as intermittent catheters. Now, the intermittent catheter was a closed system that we had the documentation to get the patient approved for at 6 times a day, I believe. This was a patient out of Illinois. And I believe that's the state allowable through Medicaid. And the state allowable for the Foleys was, I believe, and again, this is for a 1-year-old patient. I believe it was either 1 or 2 Foleys a month, which is just, I can't imagine that for my children, let alone this child. And so then, in addition to that, there's drainage bags, et cetera. So accessories. We were able to get the patient 30 Foleys in a month time frame versus the 1 or 2. And I believe we got the patient increased from 6 times a day usage with the intermittent caths to I think it was 8 or 9 times a day. And so really what it came down to was us at ABC communicating with the patient with what their needs were, taking that information back to the clinic and formulating a plan. Not to say that we were trying to falsify any documentation whatsoever. We were literally taking what was coming from the patient's mouth, providing that to the clinic. The clinic was then following up on the information that we provided to ensure its accuracy. And then I believe it was a PA and an MD that were working on the documentation together. So ultimately, it comes down to letters of medical necessity. That's a long-winded answer, but I thought the example was really good because you can get more despite what the insurance company says, is the state allowable. It's just going to take a little bit more oomph from the clinic and the respected supplier that has been chosen to supply those supplies.
Thank you. We have a comment here from Katie. She said, "Thanks for the information and great advice."
Yeah.
Thanks, Katie.
This has really been great. A lot of good information. I think one of the things that I might take home on all this was the when you showed that list of all the different companies that are out manufacturing catheters, and there's a lot of them out there. You're in a different field in that you're not the manufacturer, but you're capable of getting all those catheters for our patients. And I think most of us that are, on our side of the business know that you find the right catheter, you pick a certain tube, and then you send the patient home with that order, and then find out that the company substituted the least expensive because that's the best profitability for them. And that's just not tolerable. And I mean, there's lots of choices out there with companies that do what you do. And I think, as you said, that's one of the things that your goal is to make sure we're getting the right thing for the right patient, so that irrespective of whether it's the more expensive one, if that's the one that works best for the patient, they should get that. So I would like to thank everybody for all their time. We are getting close to the end here, so I'm going to go ahead and switch over to my screen. And again, thank everyone. Little clip about next week's program.
Anticipation is mounting for the upcoming episode of EuroNurse.com, featuring the esteemed Christy B. Krieg, MSN, CUNP, as she takes center stage to discuss navigating the world of kidney stones. With her wealth of experience and expertise in urology nursing, Christy promises to deliver a dynamic and informative session. Viewers can expect an engaging exploration of the nuances surrounding kidney stones, from the factors contributing to their formation to practical insights for prevention and management. Christy Krieg, known for her insightful and accessible approach to urological topics, is set to provide a unique perspective on navigating the challenges posed by kidney stones. As she breaks down the complexities of the subject matter, viewers can anticipate a blend of evidence-based information and practical tips for maintaining optimal kidney health. Join us this Saturday on EuroNurse.com.
Yeah, it's great. Hope to see everybody for that. Great talk. After this program at 10:30 Central Time, and we're almost 10 o'clock now, I'm going to be launching a new podcast called the EuroPatient Podcast. It can be found on europatient.com. And I do invite everybody to go ahead and watch that show. I'm looking forward to getting this launched and see how it goes. We're going to start off with this week's episode, which is what I call, What Are the 5 H's? So if you want to find out what those are, tune in. And as always, it's great to have everybody here. We appreciate all you do for us and all our experts. Thanks for all your great input. And it was great having ABC to send 3 reps to discuss their side of the business. We really appreciate that and look forward to seeing everybody next week on EuroNurse